So I'm David Paling. I'm a consultant neurologist working at Sheffield Teaching Hospitals at Sheffield. And I'm really grateful to be joined today by Jeremy. Jeremy, I wonder if you'd mind introducing yourself.
Not at all. My name is Jeremy Hobart. I'm a consultant neurologist based down in Plymouth in the southwest of England.
Well, we've got some questions that people have sent in to us about MS and their MS care. And we're going to work through those today and hopefully provide you with some answers that allay some of your concerns. So if I might start, Jeremy, the first question which has been posed is, someone's asked, is it likely that I won't be strong enough to fight off the virus with my compromised immune system?
So I think this is a very fair question and one that I suspect many people with MS will ask. And it's going to depend a bit on the specifics. So what is the individual's circumstances about being immunocompromised? And I guess that most of those will relate to the drugs that people are on for their MS. So they're disease modifying treatments that try to modify the natural history of the disease. And this is where it gets slightly complicated because different drugs are associated with different levels of risk. So we have a set of drugs that we believe pose no additional risks above having MS, and they would be the interferons, Copaxone, Tecfidera, and I'll come back to that in a second, teriflunomide, and some of the other versions of those that exist. So Brabio, for example, which is a generic version of Copaxone. Then there are drugs that we think convey a bit of a risk, so a moderate or a slight risk, and that would be, that's largely considered to be Gilenya or fingolimod. And then there are those drugs that people think may confer a higher risk, which would be alemtuzumab, ocrelizumab, cladribine, and then stem cell treatments. And some of that is going to depend on when the treatment was given. So, for example, a person who had alemtuzumab or Lemtrada, say 3 or 4 years ago, may not be at any higher risk. Whereas if they'd had that within a few weeks or months, then they may be at a higher risk. So I guess the point here is that there are individual circumstances which confer some degree of risk, and therefore I think the key thing for an individual is to be clear of the drugs that they're on and work with their team to identify what level of risk they may have, and with that, what additional things they might do to keep themselves as safe as possible.
I think that's really helpful. What drugs do you think are particularly risky? Would you say, Jeremy?
Well, I guess the ones that people consider the most risk are alemtuzumab, particularly in the early stages after a treatment course, and that's essentially because the drug depletes cells completely. So it's felt to be within the first 3 to 6 months after the treatment course, and that's considered to be the same with cladribine. And some people would argue that ocrelizumab ought to also be considered as a higher risk in the early stages after the treatment. But I think it is fair to say that we have limited evidence of the real risks and what it really means to people in the context of the coronavirus pandemic, and that we don't typically give people prophylactic drug treatments to fight off infections when they're on these treatments. And the reason we don't do that is we don't observe in real life that they necessarily have more infections. So I guess some of this is around being as cautious as possible in the context of something where we have limited information.
There's some talk in forums about people trying to work out their risk by their lymphocyte count, particularly people on fingolimod and tecfidera. Do you think there's any rationale in that, or are people over analysing the results?
I think that's a very important issue and becomes factored in with the drug that people are on. And I think this, as you mentioned, particularly relates to tecfidera and to fingolimod. So there are a proportion of people on tecfidera whose lymphocytes get quite low, and we kind of look at a cutoff of 0.8 or 800 as being the as it were the cutoff level, because that defines the bottom end of what's called a grade 1 lymphopenia. So below that moves people into a higher grade, and therefore is theoretically associated with more risk of infections. So what we have done has taken that as our cut-off level for identifying people who we would consider to be extremely vulnerable. Likewise with Gilenya, fingolimod, that lowers people's lymphocytes, and most of our people have lymphocyte levels below 0.8. But there are slightly different mechanisms of action which may play a role. So fingolimod doesn't deplete your lymphocytes per se, it just, as it were, stores them ready for action at some stage when the drugs stop. So I guess one of the things we don't understand is what the implications are of that in the context of fighting diseases and fighting viral infections. But I guess what we have done, and what many have done, is try and take a conservative, more safe approach to helping people define their level of risk. Because at the end of the day, I think it's best to be more safe than to be less safe. I'll come on to another question, and this is around another treatment, which is steroid treatment. So the question that someone has posed is, I've had steroids once with a stress-related pseudo-relapse last year. It's very stressful now, and I'm concerned about having a relapse and my need for further steroids. Am I right that steroids and COVID don't get on very well?
I'm really sorry to hear about the concern about things, and I think that's completely understandable. I think there's a few things to talk about with respect to steroids. Generally, we have been advised to try and not use steroids as much as possible during the coronavirus epidemic. And that's because of some data from both coronavirus and previous viruses to suggest that steroids aren't helpful in the treatment of coronavirus and may certainly prolong the length of time the virus is in the body for. Steroids also have a fairly limited effect upon symptoms. So steroids do reduce the reduce the length of time of the relapse. But actually, whether you're treated with steroids or not, in the long term, the data suggests that you'd recover to the same extent. So overall, we've been asked, and I agree with this, to try and use steroids for relapses as little as possible. With respect to your question as well, you did mention that your previous episodes did seem to be precipitated by stress, and there's less evidence to suggest that steroids would help in this in stress-related episodes. So it is still possible to use steroids for relapses, and we have done in people with very severe symptoms. But overall, we've tried to save those for the most severe symptoms. And I'd advise, particularly with your symptoms, just trying to act upon your stress and seeing if other techniques, for example, just taking some time for self-care and mindfulness are helpful with the stresses that you're experiencing.
In that issue around the use of steroids and relapses, that there's another related question to this, which is long, but the nubbins of it is that this person who's had MS for a little while now has had new symptoms that are suggestive of a spinal cord relapse. And he or she is not sure what to do. And I think that the issue, I guess, for me here is that for people being advised not to go to hospital unless they really need to. So what advice do you think we should be giving to people who think they may be having relapses and they're at home?
So our advice in Sheffield, and I'm sure it's the same in Plymouth, is that our services are still open. We've had to scale back a little bit because of redeployments, but we do still have a telephone advice service, and we would still like people to let us know about relapse symptoms, even if they don't wish to come to hospital and they don't wish to have steroids. There are things that we can do. So we can do telephone assessments of people. We can provide you with some information. We can give you some idea as to how long it's likely for your symptoms to improve. And this information is really helpful to us, both at the moment and in the future, in planning treatments for your multiple sclerosis. So I'd say to that person, please be in touch with your local service, see how they are able to interact with you and support you. But yeah, hospitals still are open, and we are still trying to support people in whatever way we can.
Yeah, that's good. It's very relevant because we've just had somebody exactly this with this story, and she was treated with another drug a number of years ago, which she's no longer on. She has had a spinal cord relapse. We were able to have her scanned on the same day. She's got a new enhancing cord lesion, and she starts a new treatment next week without having to go through steroids. So there are options for people. I think it's really important they don't feel that they cannot approach the teams, because we have lots of things I think we can offer them. Good. Your turn.
So the next question is, how do you know when your MS starts progressing onto secondary progressive, or can you permanently stay having relapsing remitting multiple sclerosis?
Yes, that's a complicated area for people to sometimes get their head around. So what I would say to that are, the first thing is people can permanently have relapsing MS. That there is no as it were, guarantee that if you have relapsing MS, you will develop progressive MS at some stage in the future. And I guess the figures are that roughly 70% of people with relapsing MS will develop progressive MS in the future. But those figures, I think, are historically based in a pre-treatment era. And I suspect that we are increasing the proportion of people who remain in the relapsing phase of the disease, certainly for longer, if not for the totality of their illness. Secondly, I guess one of the issues about progression, as we determine in MS, that is a gradual progression in the absence of episodes of worsening, is it becomes a retrospective labeling and evaluation, and really it needs a considerable period of time before we can and should safely say that somebody has actually moved into the progressive phase of the disease. And I guess there are a number of issues about that. The first thing is that we do see people who have so-called subacute relapses that go on and develop over a substantial period of time, rather than the short, rather acute-based worsenings that people typically describe for relapses. And we have seen people who have got worse, and you would consider had progressive the disease, and then they improve. And so the second thing is these labels can be problematic in terms of the influence they have on people's eligibility for treatments. And so we take the view that you should label people with caution in the progressive phase of the disease. Now, that may be set to change if some of the treatments that are currently going through the licensing processes become prescribable for progressive disease, because then we will have options for people at whatever phase of the disease they're in. Whereas at the moment, really, our options are for people predominantly with relapsing disease and with primary progressive disease. Any additional thoughts?
I agree. Very, very comprehensive. Thank you, Jeremy.
So here's one for you, David. The question reads: I have read that COVID-19 affects a blood type more than others. What do you think about this? And does this apply to a blood type people as well?
I have done a little bit of research into this, and there is one publication from China that I've been able to find out about this. It's not been peer reviewed yet. It's been it's just been published for everyone to see, and that's important because it means that scientists and physicians haven't had a chance to go through it in detail and make sure that the people who made this haven't made any mistakes. It does suggest that people of about 2,000 people who were admitted with coronavirus in a Chinese province, that they saw people with type A blood group more frequently and type O blood group less frequently. And that's apparently also been noted in other similar viral epidemics with SARS and MERS. It's very interesting and may help us tell us a little bit about how the virus works and how it affects people. In practice, I don't think I will be overly concerned about this. It's often very difficult to find out your own personal blood group. And the slight differences, so they found about 20% difference between the two. They're interesting, but I don't think they're enough to alter your behavior one way or another. So really interesting information, and I'm grateful to the questioner who alerted me to something I'd never thought about before. But in practice, for people with MS, I wouldn't worry about this one way or another, even if you do know your blood group.
I would agree. I guess these are things that we will learn in retrospect when this pandemic is over and they have large amounts of data from multiple different countries to analyze if they have blood group information. Okay.
So next question is, so someone's asking what support and or contact is reasonable to expect from their MS team that they've been looking after that patient for the last 20 years?
So I think it's fair to say that it's a very challenging time for MS teams. And there are, I guess, a number of reasons behind that. One is that lots of members of teams are being deployed. So our nursing staff have been, as it were, retrained and are ready, should they be required, to go back on the ward. So it does leave an area of uncertainty. And that's also the same as the clinicians. And the reason Gavin Giovanoni is not yet on this call is that he is being deployed. So it does make it more difficult for teams to respond. And as you would imagine, in the context of the uncertainty and the variability of advice, then teams are flooded with lots of questions by phone and by email, and so it does make their response a bit slower. However, I think by and large, most people will be trying desperately to keep in contact with people as best they can, and so keep working with your team to try and get responses. But also remember there are other avenues available. So the MS Academy has provided a series of webinars and discussions that will have information for you, and there are also links to blogs and information settings that can help. You can also use the MS Society and the MS Trust, both of whom have advice lines and information to help people should they be required. So I think those are the avenues that I would use if there are problems. I mean, how is your team affected, David?
At the moment, we're just running telephone clinics and advice. At the moment, no one's been redeployed as of yet, but as with your centre, some nurses have been identified who have transferable skills, and they will be deployed. Likewise, we're covering more acute medicine, so the consultant presence is reduced a bit. But we've worked hard really just to try and keep the advice line open, because we are aware that this is a really hard time for people with multiple sclerosis, certainly the most challenging time in my professional lifetime. And we want to try and help people, and we want to try and help other medical services by ensuring that we deal with people with multiple sclerosis correctly, and they don't have to access general practice or A&E for symptoms.
Okay, so the next question here is, I have a question for the session. It is, if you know a confirmed case of an MSer positive with COVID-19, what is the treatment applied, and how, and what is the likely effect on MS progression?
So yeah, we started to have some of our patients contact us who have had COVID, and they've had variable experiences. Some have had to go into hospital, others have been able to manage their symptoms in the community. It's been fairly unpleasant for the duration of their symptoms, but no one's come to any significant harm, touch wood, as of yet. People have let me know that that their MS symptoms have worsened whilst they've had the infection, and that's what we'd expect from our experience with other infections, chest infections, urinary infections. It does usually cause your MS symptoms to worsen for the duration of the infection and sometimes afterwards. Touch wood, so far, none of my patients have become permanently worse as a result of coronavirus infection. And I think it's fairly rare that I personally see people to relapse after infections, particularly now people are on disease-modifying therapies. So I wouldn't particularly be concerned about a big risk of relapse after an infection. I think, but I do think most people will notice, if they get a nasty infection, that it also will cause their MS symptoms to worsen. Has that been your experience, Jeremy?
Yeah, it has actually. We have two people in the hospital who are people with MS who are COVID positive. They are both very disabled prior to the illness. We've not had as many calls as I was expecting from people to say that they felt that they had the disease, and my understanding is that there's a study which the UK are part of, which is a kind of registry study trying to register people with MS who have or feel may have COVID but haven't been tested, or who have been tested. And the preliminary information coming out of that was implying that actually the risk in MS is not necessarily much greater, and that perhaps interestingly there didn't seem to be a big difference from the preliminary data as they are accruing to say that there's a notable difference as to whether people are on disease modifying treatment or not of their risk of getting the disease. So I think that's positive information. I guess one of the things that's thwarting our understanding is the inability to do widespread testing, because it will be interesting to know that for example, if our people like the lady who we had this week who pitched up with a bona fide relapse, was she actually COVID positive, even though she's asymptomatic from that perspective, right? And I think that's the way that we will understand better about this. But I guess we're not going to get the degree of information that we would hanker after if we were lucky.
Yeah, and just to add to that, we've got a couple of colleagues in the department who've got links to colleagues who work in Milan, which was very badly affected by coronavirus. And they echoed really what we've been noticing, that they didn't particularly feel that their patients either were presenting more frequently with coronavirus than they'd expect, or had any worse outcomes to the other people that they were expecting. So provisionally on some anecdotal evidence, some reassurance that this doesn't seem to be particularly worse for people with multiple sclerosis to everybody else.
I mean, there is of course the issue that's been raised, that whether people being on immunosuppressive agents has been somewhat protective for them in the context of COVID-19, given that the serious forms of the disease are an immunological response rather than the direct infection from the virus.
Yeah, I think that's very interesting, and I was very interested to see that there is a clinical trial of fingolimod, an MS medication for COVID that's running in China. So other people are thinking along those lines, but I think it's far too early to know.
It is interesting that though, because there have been a number of questions come in about fingolimod.
Yep.
Because of its because it does lower people's lymphocyte counts. What they could do.
I've got another question for you, Jeremy. Does it make sense to get the flu vaccination because of the risks of the disease, even though there were risks regarding the progression of multiple sclerosis?
Yeah, so I didn't know the answer to this, so I looked this up, and I looked. Actually, I got led to the Australian MS Society website, where they are recommending that people do have their flu vaccinations, because they feel that the potential double whammy of COVID-19 and influenza could be a very distressing scenario and very dangerous scenario. So that was their feeling. But otherwise, I didn't find any information otherwise, and actually I wasn't entirely sure. So I'll value your view on it.
Well, I think there's a couple of bits to this. Again, I did some research, and they are rather different sorts of viruses. So one thing I wondered is if you had the flu vaccine, whether that provides some partial protection against coronavirus. But flu is a different sort of virus called a paramyxovirus, and there's very little similarity between the two. So it won't help with coronavirus. The other thing is that the flu season's coming to an end really in the United Kingdom. So the flu season ends about sort of April, May time. So you're running out of chance to have this or the last seasonal flu vaccination. So for the moment, I don't think it's something that patients in the UK should go out and actively seek. But having a flu vaccine is actually very important generally if you do have multiple sclerosis, and if the pandemics, particularly if it carries on, I think I would recommend people get flu vaccines the next seasonal flu season this winter. And I think there's a few reasons to want to do that. The first is that there is this theoretic concern if you've got both viruses at the same time that it would be worse. And the second thing is it's likely that health services continue to be under strain, and if you're able to reduce your reliance on health services by not getting seasonal flu, that would be good. And the third thing is, at the moment, it's been difficult to tell between diseases like seasonal flu and coronavirus. And then actually, if you're immune to or partially immune to one, then it can be a little bit more clear as to what's going on. So I don't think people with multiple sclerosis should run out and get this year's or last year's seasonal flu vaccine. But I definitely would recommend it for next year for several reasons.
It is important, this issue, isn't it, that not everybody who presents with fever, cough, and flu, coronavirus infection. And I guess the kind of figures that are coming through locally are that of the people who present to us as people with possible COVID-19, it's about 30% turn out to be positive. Now, I don't know whether that differs elsewhere, but I guess it has some interesting issues in relation to our understanding of the disease and issues around testing and the importance of more widespread testing. And then for me, it raises the thorny issue of PPE at the front door, because it seems that the recommendations for PPE at the front door, i.e. people with suspected coronavirus, is much less than those people with confirmed. So you would have thought that it would be sensible to have your same levels of PPE at people with suspected before they're confirmed, rather than not. But I guess that takes us into an area we may not see into.
Yeah, and possibly something we can't address. In our hospital, actually, everyone's now been treated the same whether you've got present coronavirus or not, and I think that's probably
which I think makes perfect sense. Yeah. If it is 30-35% of people who have the disease, then essentially the numbers are such that it makes the treatment of everybody as the same as the most sensible thing at the front door. Next question. Now then, so these next few questions are on the same sort of issue of progression and coronavirus and influenza. Okay, so here's a question for you, and it's actually in Germany there is a discussion about the definition of risk groups. Brackets, elderly people and people with chronic disorders. If I am not taking immunosuppressive medication, is it reasonable to assign myself to this risk group, or do I have the same risk group as other people of my age?
It's a very good question, and the answer is that I'm not really sure. I think, and certainly the data from the WHO and NHS England emphasise that there are lots of different risks for coronavirus, and often those risks can add up. So risks that they've noted are people on immunosuppressive medicines like multiple sclerosis, people with other chronic health conditions, particularly diabetes and high blood pressure, hypertension, and frailty, particularly in elderly people. It's likely that those can add up together. So if you have, for example, if you are aged over 65, you have hypertension, you have multiple sclerosis, particularly if your multiple sclerosis affects either your breathing or your swallowing, then you may have quite a high risk. The corollary to that is if you have very mild multiple sclerosis and you're younger and you don't have any other health conditions, my view is I don't consider that you'd be very different to someone else of your age. So I think in short, multiple sclerosis may slightly alter your risk of coronavirus. And that depends upon the treatment that you're on for that and how badly the multiple sclerosis has affected you. But it's really important to take into account your other health conditions. And also, if you're otherwise fit as well, if you're otherwise biologically fit, then I think that will give you some protection. So question 12, someone has asked us that they've come off ocrelizumab because they were informed to by their doctor. Will I have a relapse?
So this is an important question, and I think it's fair to say that what has generally happened and the recommendations about ocrelizumab, that subsequent infusions are delayed. So normally it's a 6-monthly infusion, and the general recommendation at this point in time is to delay further infusions. And I guess part of that is because we're anticipating this to be a short-term problem in the grander scheme of things. But the key reason for it is that for delaying them is that soon after an infusion of ocrelizumab, you will be at a notable risk of being infected if you're exposed to the virus, and of having a more severe illness of COVID-19 if you contract the illness. Now, many people are concerned about this, but there is good evidence of a more prolonged effect beyond the 6 months. And if we look at a kind of number of situations, I guess, the rituximab showing that after a single cycle of Ritux, then the benefits can last way beyond 6 months. And we see this with other drugs as well. So we see people who've had a single cycle of alemtuzumab, their benefits last way beyond a year. And likewise, people who've had a single cycle of cladribine, their benefits have lasted ongoing for a while. So we don't feel that people are necessarily at a higher risk of developing a relapse. However, I guess the problem would come if the length of the delay became extremely long. And I guess one thing that we're going to learn from this is around the necessity for 6-monthly infusions of ocrelizumab, and whether actually people may be able to space them out further and therefore have less treatments over a period of time. So your experience here with your ocrelizumab people?
Yeah, I'd agree entirely with that. I have a lot of, I sympathize entirely with that patient. It's very unsettling to go from having something every 6 months to not knowing when you'll get the next dose. I agree with you. Often we delay treatments like rituximab and ocrelizumab for other reasons, for other infections, for pregnancy, and we don't see, I've never seen any sort of big rebound effect from doing that. I was also reassured that there is a recent study from Sweden where they use a lot of rituximab for people with multiple sclerosis, looking at people who hadn't had any rituximab after treatment for a year, and actually of the 94 people who'd stopped the rituximab, only 3 of those actually had a relapse, and three had new T2 lesions on a scan. So it does seem that it has a slightly prolonged duration of action beyond 6 months. So I'm reassured about that, but I think it is really important as well for people to keep an eye upon their symptoms and let the clinicians know what's going on. It's advised, but it isn't banned to use ocrelizumab. So I think if we did feel that people were unstable, that it is possible to have ocrelizumab. At the moment, we feel for most people that the risk is greater than the benefit. But yeah, another reason for people just to keep in contact with their MS centres, particularly when they don't feel that they're doing so well, so they can evaluate things.
Yeah, I guess from a logistic perspective, one of the complexities for patients and for teams will be that we may have a situation where we have large numbers of people past their 6-month infusion time point, and the logistics of infusing people in a timely manner may be quite challenging. So that will be something to watch. And just for the benefit of our listener, if you're a follower, ocrelizumab and rituximab are chemically very, very similar, and so we believe that they have a similar effect, and that's why we talked a little bit about the rituximab data.
Yeah,
thanks for
clarifying that, Terry.
No, that's okay. The next question: how can we ensure the frontline medical and nurse staff who are managing people presenting in extremis with COVID-19 are made aware that people with MS are individuals, many of whom have a quality of life worth living, rather than a homogeneous group of people unlikely to survive and or not worth the scarce ventilators? So I guess this question resolves around young disabled people who with COVID-19.
Yeah, I understand entirely the concern of the person who sent us in that question, and I sympathise with them. And I think this has probably arisen from a couple of things. First, that there were lots of concerns early on in the coronavirus pandemic in Italy that there weren't enough ventilators to go around, and that clinicians were asked to decide who would benefit more. And certainly my experience, and I think the experience across the country, is that there is availability of critical care beds, and we're not at a situation where doctors are having to prioritise one person over another. The other reason that I think this came to concern is that NICE put out some guidance, and in the guidance they indicated something called the clinical frailty score. This was widely misinterpreted as showing that people who were frail, who weren't able to walk properly, shouldn't be offered a ventilator. Actually, the guidance is pretty clear that that's not the case. You can only use the clinical frailty score in people who are aged over 65, and you can only use the clinical frailty score where people don't have a chronic neurological disorder. And in most people with multiple sclerosis, neither of those would be the case. What I'd say to people with multiple sclerosis is it is really important, if touch wood you don't get to that stage, but if you do need to go into hospital, that you and your family have thought about the treatment that you would want and how aggressively you would want to be treated, and if you do wish to be ventilated if you need. But also that if you do wish that to happen, that you're upfront with the doctors looking after you and explain why that is the case. In my experience, doctors would welcome you bringing that up in the conversation and your reasons why that is the case. And the guidance suggests that we should take people with multiple sclerosis views into account as to what they'd want, and there's no obligation that doctors aren't allowed to treat people with multiple sclerosis, even if you're disabled, providing you understand what the team is telling you.
Yeah.
Does that match with your feeling about things, Jeremy?
Yeah, exactly. It is, I guess, that it seems to date we've had less of an acute rise in cases that they've had in Italy and in Spain. So I think we've had less of these issues. But I do recognise that some of the messages that appear to be coming out are not very positive for more disabled people. And what I would say is, you interact with the doctors and make aware that you're under the MS team and you want them involved in discussions about you, because most of us will fight very hard to protect your views. And I do think, as you say, that any ITU teams involved would very much like to have the input of people who are involved in the wider care of people, because these are very challenging decisions to make.
I agree entirely. Next question is is again about people's particular risk, but it's the questioner said, I've read and been told that people with multiple sclerosis aren't at particular risk of COVID-19 if they aren't taking immunosuppressant disease-modifying therapies or have other health conditions which make them vulnerable. But now that we know that the virus is killing healthy and young people, can we be sure that that's true?
I guess the simplicity is that we can't be sure because this is a new arena for all of us, and therefore we will only know in retrospect some of these issues. I guess that I have the same view as you mentioned earlier, that by and large, having a diagnosis of MS does not necessarily confer a higher risk of catching the virus or of having a more severe form of the COVID-19, unless you are more disabled, and particularly in the cases where breathing and swallowing are involved, or people who are on specific drugs that render them more susceptible. I guess what we do know is that there always will be some young, fit and healthy people who will succumb to these sorts of infections, and part of this is purely the numbers involved. So I think the latest figures I saw was there's somewhere in the region of 100,000 people tested positive in the UK, if I'm right. So if you have that many people who are testing positive for a disease, then there will be some people who are young, fit and healthy who will catch a disease and have a severe outcome. So question for you. Until we have a vaccine, is the only way out for all of us, or the great bulk, to get the virus and suffer for whatever fate brings us, and the only defense be a year or more of isolation?
So it's a very good question. I don't know the answer to that really. I think until we have a vaccine and also a way of telling who's immune and who isn't immune, we're probably going to have quite big changes in society, prolonged societal social distancing. Yeah. But beyond that, neither Jeremy or I are virologists or epidemiologists. So I think beyond that, I can't really help that questioner, other than to say just watch this space and listen to what the virologists and epidemiologists tell us. Yeah,
and I guess over time, as we learn more about the disease, get better at treating it, and there are the results of some of the treatment trials of repurposed drugs, then it will be the safer you are, the better the likely outcome. So I was wondering whether we might move on. There's a set of questions, actually, which I think are very relevant, which are around this identification of extremely vulnerable people. And how are the lists of people who are sent a text to say they are in this extreme risk category, so need to self-isolate, being made? Is it just the criteria on the MS Society website, or is there input from individual MS teams or individual trusts? Some people are getting letters, others on a treatment such as ocrelizumab, but others who are on ocrelizumab are not. So identification, the identification of high risk.
So it's an excellent question, and this respects to the specific rules about shielding for people who are deemed to be extremely vulnerable. So the Association of British Neurologists has looked at that, and it's identified some groups that it thinks are extremely vulnerable. Those are people within 3 months of alantuzumab or cladribine, within 12 months of autologous hematopoietic stem cell transplantation, or with significant breathing or swallowing difficulties as a result of multiple sclerosis. There's been a number of ways that these patients have been identified, but I don't think all of them have been perfect. So the NHS the sort of the digital part of NHS England have looked at both hospital episode statistics and the GP coding databases to try and identify these patients. The problem with that, the information's only as well, that's only as good as the information that's put into the systems, and often that isn't that great. Each trust has also been asked to identify patients who might be on this list, and each hospital trust will have a designated person who's responsible for coordinating this. And certainly we've provided some lists of patients to that from our databases. I think what I would let people with multiple sclerosis know is that this has been a very valiant effort, but it isn't perfect, and there have been mistakes both ways. Certainly some patients have been identified who we don't feel would be extremely vulnerable. They've been mistakenly identified and put on that list, and we're not sure how their name got on that list. Likewise, we have had calls from people who we would consider to be extremely vulnerable, and they haven't yet received a text message or a letter from the government. So it hasn't been perfect. There are some things that you can do if you think you've been put in the wrong category. Actually, when you do get the text message in the letter, it does let you know that if you feel that you've been mistakenly put in the category, that you can contact your GP or your consultant. And if you do think you have been, I would suggest that you do that. And a few people have contacted us, and we've been able to reassure them that just doing the normal thing is the appropriate thing to do. The corollary to that is if you do feel that you should shield because you would be at high risk, then your MS team is welcome. It can let you know, or your GP can let you know. And you can register on the government website. I'm sure we can send you put the details on the MS Academy, but you can register on the government website. And once you register on the government website, they'll help to allocate you help getting food and medications if you need. And again, if you're not sure, I appreciate MS teams are under a lot of pressure, but that is something that the MS team can help you with, particularly where your situation might be a bit more complicated, where you've got lots of other health conditions to be taken into consideration, or a particular social or occupational condition to be taken into consideration. Jeremy, has that been your experience with these letters?
Yeah, very much so, and I guess it has caused a lot of confusion, and we understand that. And I guess one of the issues we've had a slightly different scenario, in that what we did, we identified all our people and we contacted them personally and sent them the government's letter. Now, they then tried to register on the government's website, and it wouldn't accept their registration. And that's because the trust has to notify NHS England of anybody who they think should be considered extremely vulnerable. And until the trust identifies people, then they can't actually register with NHS, with the government, through the letter that we sent. So there has to be this dual process of they get trust sign off, as it were, and then you're eligible for the benefits that are there for you. But what trusts can do and are doing is providing a set of local contacts and numbers for those people who are in that position where they've been identified, but the trust has not yet got round to informing NHS England. And I guess part of this is the trusts are often trying to do this in a wholesale way. So they want to send one list to NHS England of people, because I guess NHS England will be saying to them, we don't want to receive updated lists each day. We really want one list. And so of course, the compilation of a single list is unbelievably difficult because it depends on all sorts of scenarios. So that process of the trust informing NHS England is likely to lag behind the MS teams informing people and identifying people. So there may be a mismatch, and that certainly for us, that's caused a degree of angst for a lot of people, and fully understandably so. But what the trusts have is they do have interim contact details where people can be assisted under those circumstances. So,
and they've actually, for the benefit of the patients watching this, they have actually changed the system. I think as of yesterday, Jeremy, that you can register even if the NHS isn't aware of you. So that has been changed. I think yesterday or this morning, and it seems from so far it seems to work okay. I talked someone through doing it this morning, and it seems.
Well,
that's
I'm delighted that that's happened, because we identified our people on the first of April when we because it's interesting, isn't it, that the time taken for some of these processes to play out. So the letter from the Chief Medical Officer was dated the 21st of March. We received it on the Saturday, the 28th of March. And prior to then, we were looking to identify people, and we had different criteria, etc. So it was only after then, and I know locally they've had some difficulty compiling their list. So I'm delighted to hear that they've changed the goalpost there, because that's much better for people.
And I would say if anyone's been in the situation that Jeremy's patients have been in before, it's worth just rechecking and going back on that website. And it sounded not too difficult registering your details. Once you've registered your details, you then able to get extra assistance for getting medications and for getting food.
Okay, that's excellent. That's good to hear. Now then, here's a question for you. Any further evidence around vitamin D, a lack being contributory, or a high dose of acting preventatively? So let's broaden that out about the role of vitamin D. And I guess one thing to raise is that there have been some posts about vitamin D levels being helpful for people in the COVID-19 pandemic, but then we'll move on to the generality of vitamin D and MS.
It's an excellent question. So quite a lot of people with multiple sclerosis have low vitamin D levels, and there is an association between low vitamin D and worse MS outcomes. It would be fair to say that despite this, all the trials to date of vitamin D supplementation have been fairly disappointing. But that doesn't mean that it's not a good thing to do, and it also has beneficial effects upon other aspects of your health. So in general, I would recommend to all patients with multiple sclerosis, either you get your vitamin D level checked and treated according to that, or if that's not available to you, that you take a vitamin D supplement. There have also been some preliminary evidence to suggest that people who do badly from a coronavirus tend to have lower vitamin D levels. Again, we're at the same sort of situation where we are with multiple sclerosis, that it's not clear whether having a low vitamin D level causes you to get more sick because of coronavirus, or if actually the contrast is true, that you the disease process in the coronavirus also causes your vitamin D levels to be low. And we won't know that really until probably after the end of this. I'd recommend everyone either to get your vitamin D level checked or to take a supplement and we often suggest about 1,000 to 3,000 international units of vitamin D, which you can purchase quite easily over the counter. Is that what you're feeling, Jeremy? Do you have any other thoughts about things?
So I guess I have seen a number of comments and pieces around vitamin D levels and COVID-19, and there was something recently saying that, as you said, people on ITU have low levels of vitamin D. But what I would say is that we do routinely on everybody who comes to our MS clinic, so suspected MS, possible MS, abnormal scans who don't turn out MS, and the levels of vitamin D in general are very low. So it's probably there's certainly a general thing versus a specific issue in MS. That's one of the difficulties with the vitamin D story, is the difficulty of studying it. There's no money in it, so it's not an attractive proposition for a funding body to organise an expensive study to provide stronger evidence that a vitamin supplement works, when it's actually cheap to buy over the counter. I guess our anecdotal experience is that those people who do engage with vitamin D supplementation, they do seem to do better. They have less problems from their MS by and large, and they get associated infections in the winter months, etc. And I think that's the same for all of us, not just people with MS. So I do believe there is value in it. But like many of these circumstances, there are multiple factors involved in managing diseases, and it's a piece of a jigsaw that if you put all the pieces together, i.e. you manage well, you engage with your team, and you are diagnosed early and managed well, and you're monitored well, then the chances are that you will do better, and I think this contributes to that.
So my next question has been sent in, and it's quite a complex, both clinical question, but also helps us explore the difference between shielding and social distancing. So the question is asked: I'm currently taking fingolimod, which, as you know, suppresses the immune system. I've been on the medicines for 3 years now, and during that time I've had 3 to 4 chest infections a year, which have needed antibiotics. I've also had shingles 4 times in the last 5 years. Based on that information, what do you feel that person should do?
So based on that information, I would say that this person is expressing indications of being immunosuppressed, and therefore they should be shielding, not simply self-isolating. And shielding is the recommendation for people who are extremely vulnerable. And I would say if somebody has had 4 episodes of shingles and 3 to 4 chest infections per year requiring antibiotic treatment, that then they are at risk, at high risk of catching this virus if they are exposed, and if they catch it, of having a more severe COVID-19 infection. And so the shielding recommendations are outlined in this government's letter that gets sent to people, and it's on the government website, and that's actually on the academy website as well. But you know, I have the letter in front of me here, and just to read out some of the recommendations, which are the simple ones: avoid contact with people with COVID-19, do not leave your home, do not attend gatherings, do not go out for shopping, leisure and travel, keep in touch by remote access, And then there are specific things within the household. Minimize the time you spend with others in shared spaces. So that's within your own household. Keep 2 meters away from others in your household. Sleep in a different bedroom. Use separate towels, and if necessary, use a separate bathroom. Avoid kitchen use when others are present. So there is a very, very significant difference about the recommendations for shielding versus self-isolation and social distance. And I think that's an important issue for people who are considered extremely vulnerable to take on board, that they really need to get into the nitty-gritty of this, because this is about protecting them from a potentially lethal condition. And so I would say to this person that you should be considering these things very, very seriously, because the fact that you've had so many infections does imply that you are one of those people who is vulnerable to getting them. Now, the extent to which that can be attributed only to the fingolimod is always very difficult. But I think to maximize your protection, follow those guidances.
I think I'd agree entirely with Jeremy, and I think it's a really it's a really helpful question, because in general we wouldn't necessarily recommend that people who are on fingolimod should shield, and certainly the ABN criteria wouldn't say that you should shield, but it just shows that extra things about your condition are really important in doctors working out how vulnerable you would be. And I think again it shows that if you are concerned that you do get infections frequently, that you should be getting in contact either with your MS team or your GP, just to help them to work out your risk. And even if you don't fulfill those criteria, your doctors are able to sort of look at things that you tell them and work out your risk and provide you with a letter. And you're now able to use that letter to register straight on the government website. And also, I think you made the point really well, Jeremy. Shielding is a very is pretty extreme in terms of the things that you have to do.
I would add to this that sometimes your MS team aren't fully aware of all these things. So, for example, if you go to your GP with another infection, they give you more antibiotics, that information may not come back to the MS team and may not be pieced together as being a set of episodes. So conveying that information to your team is really important. We would encourage people to keep a note of these information. So for example, I was contacted by somebody a couple of weeks ago as to whether she is highly vulnerable, and I look back through all the notes we have on her, particularly in terms of a documentation of a susceptibility to infections, and that we had none. I rang her GP and she said 6 courses of antibiotics in the last 18 months. And the transfer of information in our health systems is less complete than we would like it to be. And as the person in the center, you're the gatekeeper of this information. So the better you keep a record of this information, the better you will help us to manage your care. But I guess the next bit of this question takes us into an interesting territory, is what would you do if this person was under your care and at this stage you were told that there'd been multiple infections and multiple episodes of shingles? So would you recommend a change in treatment?
So there's a couple of things. So I'd entirely agree with you, Jeremy, that putting all those things together, I would be concerned about that the fingolimod was making them overly immunosuppressed. There's a couple of options that we would have. I agree that patient ideally should shield. what's also implicit in how difficult it is to properly shield is actually how it's not possible for everyone to do. For example, if you're looking after children, you're looking after a vulnerable relative, or by virtue of your employment, you don't consider that you're able to shield. It isn't an option that is available to everybody. So I think I would take into account that person and how they would be able to do that. There are other options for their treatment as well. We could consider switching to a treatment that we consider to be less immunosuppressive. That would depend upon the specifics of that person's multiple sclerosis. But for example, we're able to use natalizumab a little bit more liberally than we have done before, which is an infusion treatment, but it is regarded as having less impact on the immune system, or using a perhaps slightly less effective treatment, but one with lower impact upon the immune system, like Tecfidera or an interferon. So if you were in that situation and you were concerned about things, again, it would be really important just to get in contact with your MS team and explore all your options, particularly if it was going to be difficult for you to completely shield yourself.
Yeah, it is that, as this person goes on to explain later in their part of the question, they do have a very complicated scenario. So I live with my parents, who are both in the severely vulnerable category, and I'm a teacher, so lots of contact with youngsters and infection. So it's some of these situations are very, very complicated.
Yeah.
And you are right that being in contact with your MS team to talk this through and try and develop a clear strategy would be a very sensible thing to do. We feel for you. Poser of question number 21. Here's on a slightly different angle. This is question number 23, which is, I guess, asking us to be a little bit more speculative to the future. Is or will the global pandemic have any significant impact on any new treatment pipelines?
Yeah, it's a really good question. I think it will to a certain extent. Certainly for a number of reasons, we've stopped doing any new trials in treatments of multiple sclerosis, both because we can't be sure how safe those medications would be if people did develop coronavirus, and also because a number of staff in the research unit had to be redeployed, and I think that's the situation globally. So I think it will impact at least 6 months worth of new drugs. There are still some studies that are ongoing, so we're still carrying on with a couple of studies that we are running that we think we can do safely. And actually it is having some impact upon those studies, perhaps for the better. We're doing many more of our visits remotely, which actually patients are much favouring rather than coming to the research unit. So I think it also will change the way in which studies will be done, and some of that may be for the better in the long term, but in the short term it has caused quite a lot of disruption. Is that your experience as well, Jeremy?
Yeah, exactly the same. It's caused a huge upheaval. It's caused some paralysis in trust for things. But there are some very positive aspects, and I think that it has demonstrated to us that telephone follow-ups, video consultations, and these mechanisms can actually be very, very valuable, and they don't necessarily detract from the quality of care. In fact, they may well improve it, and it's much more convenient for people. There's
an excellent webinar run a couple of days ago by doctors in Cornwall and in Scotland about their experience, and they made a very good point that actually when you talk to people in their own homes, that they're often much more relaxed and much more able to tell you about their symptoms. And I've definitely noticed that this week doing video clinics. So it's forced us to work in different ways, and hopefully one of the silver lining for this terrible cloud is that we are exploring different ways of working, and that I hope that when all this is over, we take the goods, out of this terrible situation.
Yeah, I agree entirely. So here's another one for you. Are there any new drugs or procedures coming soon that they hope will make MS treatment in a new, or will take MS treatment in any new and exciting directions?
What an excellent question. Think things are looking really exciting for a couple of avenues in multiple sclerosis. Although this corona pandemic has slightly changed them, that there are sort of generations of therapies for people with progressive multiple sclerosis coming through. We're starting to use ocrelizumab for people with primary progressive multiple sclerosis, and there's a new medication called siponimod for people with secondary progressive multiple sclerosis. These both have quite significant effects upon immune systems, so it's likely that we're going to pause the initiation of those treatments, but I am excited over the longer term, once all of this has settled down, to see the impact of those drugs, and actually taking a little bit more of a detailed look using scans and assessments into actually what's going on at a pathological level in people with multiple sclerosis, and treating inflammation when we see it, and not being so bound up by labels. Beyond that, there are some treatments underway. There's a phase 3 treatment of statins in secondary progressive multiple sclerosis. They're incredibly cheap drugs that are very widely available, and if that trial is positive, it's likely everyone in the world in multiple sclerosis will start on a statin. So there are some things that are still going. Things haven't stopped in the world of multiple sclerosis, and we are still looking to make things better. Jeremy, is there anything else that you feel that you're excited about, or that you're looking forward to for the future?
Yeah, but I'm going to back this back to you, because you're in the centre that is pioneering studies of stem cell treatment for MS, and I wondered if you'd give us your views, your experiences, and your thoughts on the future.
So in Sheffield we do a small number of treatments called autologous hematopoietic stem cell treatments, which is currently an experimental procedure for people with multiple sclerosis, but one that we found has been very effective, particularly in people with very bad relapsing remitting multiple sclerosis. What remains unanswered, particularly with the advent of better and better treatments for multiple sclerosis, medications like natalizumab, ocrelizumab, and alemtuzumab, is whether that it's significantly better than these medications. And there is some data from some small trials to suggest that it may be better than those medications in stopping relapses and stopping MRI activity, although those studies aren't the same as the studies that are done for drugs. There is a study that is almost ready to go, but has had to be put on hold for the moment, called StarMS, comparing autologous hematopoietic stem cell transplantation to standard high efficacy treatments in people with multiple sclerosis. And there's several other studies that are similar going on in Europe and the States. And the question is whether, particularly if you start this early, whether it gives a benefit. We're really excited about that. It's a shame that we've had to hold off on that at the moment. It isn't a very safe treatment to use in a coronavirus pandemic, but I'm hopeful that once everything settles down, that we'll have an answer for the MS community as to whether that's the case.
And is the experience of your group that very early stem cell transplants are looking like they will be preferable, or is that less of an issue?
So I think with every treatment in multiple sclerosis, you want to use you want to start it as soon as you can to prevent the accumulation of disability. And we haven't really seen any clear indication that the stem cell transplants do anything other than switch off inflammation, and they just do it in a better and more extensive way than other treatments. We have seen some people with some really impressive reduction in disability associated with stem cell transplantation, but I think that's mainly due to recovery from relapse rather than anything else more profound than that. Some of the studies in stem cell transplantation, particularly the MIS study, did show a reduction in disability, and I'm really keen to see if we see a similar thing with the RRMS study, this study that's planned throughout the UK, looking at comparing autologous hematopoietic stem cell transplantation to essentially otherwise best treatment for multiple sclerosis. Currently, that's going to be either ocrelizumab or alemtuzumab, but that may be reassessed again depending on how things are in a few months' time.
Do you have a feeling on the potential of combination therapies?
What do you mean, like a combination of
different disease-modifying treatments with different modes of action?
Yeah, that is a really good that is a really good question, because we do recognise that even in people who we consider that we've treated the inflammatory component of the disease incredibly well, some of those people will continue to gradually accrue disability, and we presume that's by another mechanism, by more a neurodegenerative mechanism. That's sort of the hope with the MS study, that simvastatin is working in a different way, in a way separate to an anti-inflammatory. But I'm not, and I think it definitely is the way forward for MS treatment. But I'm less sure that we have some good medicines for that. Do you have any thoughts on that, Jeremy?
I guess that what I see in MS care development and treatments is a set of parallels to the management of lymphoma. Except we're a decade behind where they are. And what I guess what I've seen more recently with them is a really impressive use of combination treatments. And so I guess my feeling is that there has to be some huge potential in this. I guess one of the difficult issues here is giving people multiple different immunosuppressant drugs for an extended period of time is okay in a disease where untreated you'll die quickly, versus a disease where where it's potentially disabling, but the outcome is much less clear. So those are some of the issues that I guess we have to wrestle with over time. But I do see it as a big area for development going forward. The other thing that I think is going to be an important development when it comes will be EBV vaccination. And I know there are people who believe that this will have a dramatic effect on the incidence of MS, provided it's safe and effective and used early enough. But again, I guess one of the things about the MS area is that it is a very vibrant place with huge opportunities for future developments. We have some 200 plus drugs that are in various stages of development. We have combination treatments, we have vaccinations, we have stem cell treatments. We are very, very fortunate to be in an area like this. It's unusual within neurology, and it's very exciting, I think, for the MS community. So David, another question for you, and a very important one. Do we have any rights to stay off work when it comes to self-isolating if we are not in the extreme risk category, but are still in the wider vulnerable group?
Yes, there's quite a lot of information about this actually on the MS Society's website, which is really well laid out. I'd encourage your patients to have a look at that. Essentially, if you have to self-isolate because either you have symptoms yourself, or you're self-isolating because someone else in your house has symptoms, and if someone else in your house has symptoms, you have to self-isolate within your house for 14 days. If you're not able to work from home, you are eligible for sick pay, either by your employer, or if your employer doesn't offer that, then you're eligible for statutory sick pay from the government. With respect to your situation more widely, if you do feel that you do need to stay at home because you're concerned about your multiple sclerosis, you've got a couple of options of things that you can do. The first is that you need to get in contact with your employer. Your employer is obligated to make every possible step to allow you to work from home, and you should only go to work if that's not the case. If again you're particularly worried about your work, there's a couple of apps that give you some protection. The first is the Equalities Act, and that does mandate that your employer has to make reasonable adaptations to your work. And that may include working from home if you are a particular risk of infection. And I think that would apply to lots of people on disease-modifying therapies. The other thing is that your employer is obligated to do something called a risk assessment and update that risk assessment whenever the risks have significantly changed. And I think your employer would be obligated to update your risk assessment. And the third thing you can do is you can ask your employer to furlough you via the government's coronavirus job retention scheme. Your employer doesn't have to do this, but it will provide your employer with 80% of your salary at no cost to them, and they may be willing to do that for you. So you do have a couple of options, but I would encourage you to look both at the MS Society's website and the MS Trust website. That has a really useful step-by-step guide as to what to do if you do find yourself in that situation.
That's incredibly helpful, actually, because we do meet situations. I had a contact from someone recently who has MS, and he is, I guess, he uses a stick to walk. He's very concerned because in the workplace it's very difficult for them to practice social distancing by just the nature of the work they do. And so he was asking advice about what his rights are to stay off work. It's really difficult, isn't it?
It is very difficult, and particularly some employment, if you're a police officer, a teacher, or you work in a prison, you can't guarantee that people will stay away from you. But yeah, I would advise going to your employer and going armed with the knowledge that you do have a lot of entitlement to legal protection, and that they should be looking out for you.
And that's all on the MS Society website.
That's a really good. That's where I got that information from. It's a really good source of advice.
That's really helpful. Thank you very much.
Thank you both for your time and all the questions that you've answered.